Thanks so much, Anna. And yeah, welcome everyone to today's session. I will do my very, very best to leave us plenty of time to ask questions. This is the first time kind of giving this updated talk on respiratory tract infection prevention. And so we'll try to move through things at a reasonable pace. So as mentioned, I'm John Lynch. I'm an infectious diseases doctor. I'm based over at Harborview. You can see in this picture here, taken by a colleague, Sandra Below, who is a pediatrician in the community. I work right up in the top of that tower for those who aren't at Harborview in parts of your work. Okay, today the topic is the air we share, how to outsmart respiratory viruses, tiny foes, big lessons, and what actually keeps us healthy. In terms of disclosures, I don't have any financial disclosures. I don't work with any pharmaceutical companies in any way, shape, or form. And I also say that I'm a huge fan of vaccination, and that's going to be a theme that we're going to touch on multiple times during today's talk. So when we talk about respiratory tract infections, the viruses I'm going to be touching on can cause lots of different types of infections, but the primary ones that we're going to be focused on are respiratory tract infections and the viruses that are associated with that. Respiratory syncytial virus, RSV, influenza, COVID-19, but there are many, many others, some of which we test for, some of which we don't, and probably even some which we don't even know the names of or exist. But we do know where they tackle, right? They tackle our nose, our throats, our upper airways, our trachea, our bronchioles, our bronchi, our lungs. And the manifestations of those are everything from having a runny nose to a sore throat, a cough, sneezing, trouble breathing, right? Bringing up lots of sputum that can interfere with that breathing, and actual, more serious things like how we exchange oxygen and carbon dioxide in our respiratory system, right? Which can put us at high risk for hospitalization, needing critical care, or things that are even worse. So the range of diseases that are involved with these respiratory tract infections are broad. And I'll say also that, things can happen outside the respiratory tract that have to do with that primary infection happening in that place, right? A very serious influenza infection can lead to lots of other parts of your body having trouble. We all remember through COVID-19, through the pandemic, things like losing sense of smell or sense of taste, right? Or some of the cardiovascular outcomes associated with that. So these viruses can do a lot more. But our focus today is really on respiratory tract infections as well as the viruses that I mentioned. So we live in an invisible zoo, right? We are surrounded in, bathing in lots of different types of bacteria, fungi, other, parasitic organisms and viruses. And when we think about, I know that the folks on this call run the spectrum from potentially, wild experts in virology and viruses to folks who may not talk about this every day. So I'm trying to hit that middle ground around the language and terms that I'll be using. So, respiratory viruses are just extremely tiny organisms that we can't see and that are opportunists, the ones that cause disease, right? We may encounter them and sometimes we have no downside, right? And then other times they can put us in the hospital. And they may move between someone who has no symptoms to someone who is at much high risk for disease progression and does develop symptoms. So they love to crash our parties, the health that we have. And we share these viruses continuously in all aspects of our lives, right? In our home situations, if we live with other people, in our social situations, in the grocery store, in a restaurant, in our workplaces, indoors and outdoors. And like how much free air is out there, how much filtered air that we're breathing in and out, things like masking, distancing when we're ill, all impact this transmission sort of network, being part of this invisible zoo that is part of just being alive. We're going to be talking about three main viruses. I'm happy to talk about others, but these are the three big ones that we have a lot of attention to. We have a lot of metrics around and data around, and some interventions that are really important, right? So first, influenza. This is a fast, furious, and seasonal virus. There are a couple of flavors of this, which I'll describe more in depth here shortly. Typically very seasonal here in the Pacific Northwest. We see this, usually coming up in late November, December, January, February, and then starts to go down. Sometimes with some some like biphasic activity. RSV, or respiratory syncytial virus, is a virus we've historically attributed to serious infections in very small infants. It can be sneaky. It tends to come up very early, so it's typically the first respiratory virus we see in the air. But what we're learning is that it probably plays a really big and important role in adults, particularly older adults, adults with other medical problems, particularly lung disease and similar. And so it actually plays a much larger role than we used to think when I started training many years ago. And then COVID-19, right? The causative, the disease that caused the pandemic and still continues with us, right? And has changed a lot of how we talk about respiratory viruses and the prevention of those respiratory tract infections going forward. And just as a note, COVID-19 is the disease caused by a virus called SARS-CoV-2, but I'll be referring to it as COVID-19 today because I think that's kind of the way everyone thinks about it. And I'm going to keep looking at you. If I'm going too fast, you let me know, okay?
Doing great.
Okay. Okay, so how they invade. So it's nice to know or think about like what are some of the technical parts of how we get an infection, right? So we have to be exposed. Someone else generally has that virus. They cough, they sneeze, they talk. It moves into aerosols and droplets that move out of them and into space or surfaces that we then interact with, either the air we breathe in or the surface that we may touch. And then we make that contact with usually our upper respiratory tract mucosa, sort of the soft, wet materials or tissues in our nose and our mouth. Sometimes our eyes as well can play a role. And those viruses then find other cells, our cells, that have receptors. So the viruses will have a protein on their surface that then can interact with a protein on the surface of our cells. And through some really cool and complex interactions, with the right receptors on both ends, those viruses then get taken into cells in our body where they can then overtake the host cell machinery and start making a lot more virus, which leads to the cascade of effects and ultimately infection. So our cells are sort of the virus nightclubs, right? They find a way to get in, they gate crash, they attach to our receptors that are there for other reasons. And they've used that to get into our cells and start replicating and moving on to other similar cells in our body, right? So they have fake VIP passes. They fake their way in using our host cell receptors. And that's really important because understanding that helps us understand how some of these our vaccines work, right? How some of the therapeutics work, because they're really, the goal here is to prevent that connection between that virus and our cells via those receptors. Okay, when we get an infection, we have an immune response, even though they're coming into our cells in these different parts of our upper airway, right? In our nose, our throats, our bronchioles, our alveoli down deep in our lungs, right? They get in there, but we start developing an immune response. First, a non-specific immune response that brings fluid and things like neutrophils or pus cells to that space. We can start generating mucus, right? Which is the stuff we cough up and sneeze. These little hairs in our airways called cilia start trying to move this stuff up, move everything that's coming down our tracheas into our airways up to the top, which is why we're trying to cough and expectorate as part of this whole process. There's mechanical processes, there's cellular processes as our first line of defense. And that's why we have runny noses. That's why we have coughs. That's why we cough sputum and similar. And then over the next, days and weeks, our adaptive immune response starts kicking in. So this is where our immune response actually targets that specific virus via one part of the virus or multiple parts of the virus. And those little pieces are called antigens. And so what happens next is those antibodies that are specific for those antigens or parts of our cells respond. T cells and B cells respond specifically to those antigens as well. And they build up a big response to target and kill the cells that contain those viruses and to bind the viruses themselves so they can be taken up into other parts of our immune response and get chewed up. And so this is like a home alarm, right, that goes off. Sometimes even in a mild infection, right, the virus itself isn't causing that much trouble, but our immune response can be very robust and sometimes even overwhelming and lead to things like sepsis or septic shock, where our blood pressures may go low, our heart rates go high, and our bodies have trouble keeping up with this immune response because it is such a big alarm that we may not be able to compensate for it. And so sometimes that viral infection in and of itself isn't the main problem. The virus itself isn't causing enough destruction in our bodies to necessarily hurt us or put us in the hospital, but our immune response to that infection is what's really driving the problem here. And this goes on to much more complex interventions in healthcare around how do we deal with that immune response, primarily by dealing with the virus or the other infection itself. And so most of the symptoms we have, the runny nose, the cough, the trouble breathing, are the result of our immune response to that viral infection and not the actions of the virus itself, which is, again, a really important topic and hopefully a target for future therapies as we learn more. Okay, who's who? So I mentioned flu, RSV, and COVID-19, and it's also worth understanding sort of the temporal trends of these, right? So in Pacific Northwest, in North America, typically flu is a winter virus. It tackles all ages, with a special predilection for the very young, and the very old, and people with other medical problems, or people who are immunocompromised, getting chemotherapy, have a solid organ transplant, all kinds of reasons. There are annual vaccines, which I'll go into more in depth here shortly, and there are antivirals available. RSV is typically a fall-winter virus. It goes up very dramatically, very fast, usually in the late fall, and we typically see it in babies and children first. That's, if you go to emergency departments in the fall, you'll see a lot of kids coming in with respiratory tract infections, and a lot of those infections are due to RSV. And then historically, we haven't tested adults as much as we've tested children, but as we've gotten more of those tests into our clinics, emergency departments, and hospitals, we've been testing a lot more over the last decade, and we've realized that this causes a lot of problems for older adults as well. There is vaccines and immunotherapeutics available. The vaccines are limited to certain groups, and right now, based on the data that's available, and we have immunotherapeutics for some babies, which is really cool. COVID-19, we're still learning about this. Right now, in the last couple of years, we've had sort of two phases, sort of a summer wave, which we had this year, and then a winter wave. But what I have seen is that the size of those waves seems to be getting smaller, even as we encounter new variants. But still, we'll see what this winter shows. Last year's winter never kind of came up to the prior winter, and hopefully this winter will even be lower. So I would say right now, this is a year-round virus. It typically comes up in the summer and the winter. So we need to think about it now. It's an all-ages virus. Definitely impacts older adults and babies more. It also impacts pregnant people and people with comorbidities, just like RSV and influenza. And we do have boosters, and there are antivirals available. Okay, so let's break down a little bit about influenza, just so we understand some of the intricacies of this. So this is some of my artistic handiwork to make you help understand. So flu A, influenza A. So when we think about influenza, we think about two main types in humans. There's influenza A and influenza B. And the reason I bring this up is because when we think about pandemic influenza, right, 2009, H1N1, when we think about H5N1, the avian influenzas, those are all influenza A's, and they're the ones that lead to big pandemic outbreaks. And the reason that that's a problem for influenza A is that because influenza A is a zoonotic virus. It's a virus that infects animals and humans. So typical large groups of animals that influenza A infects are like fowl, like chickens. It also infects pigs. And the challenge in why influenza A is so dangerous is because it actually has a segmented genome. So the genome is actually in little pieces. And if a chicken or a pig or a human gets infected with two different influenza A's, right, an H5N1 and an H3N2, it can recombine and make a new version of influenza A that people may not have immunity to. and then can transmit throughout the entire planet very quickly. And this is exactly what happened with the 2009 H1N1, right? This was a pig, chicken, human recombination event that happened in the Western Hemisphere that led to a massive pandemic that impacted, all age groups. And at that time, kind of interestingly, a lot of younger, typically healthy people who hadn't seen that type of H1N1 in the past. And so the zoonotic nature of influenza A is a real danger. And that's why we pay so much attention. The vaccine that we have, which I'll talk about in a few minutes here, usually covers the two most common influenza A's. For our vaccine here in the Northern Hemisphere, we look at what happened in the Southern Hemisphere and looks at what's the probability of what's the two most common influenza A's that are out there. And we incorporate those into this year's flu vaccine to cover that and hope for the best, because we have no tried and true method to absolutely know, what's going to happen when we put these vaccines together in the spring of the year, what's actually going to pop up in the fall and winter, in part due to this potential for recombination. This is also important for influenza A. Seems like a complex slide, but I really want to bring it down to is that bottom part. So we think about influenza A's. Well, those are shorthands for much longer names. And you can see at the end of this, H3N2. So this long name delineates a specific type of influenza A that we would mostly call, influenza A, and then we probably call it H3N2, right? And so whenever you see H3N2 in terms of an influenza virus, that's a reference to influenza A, one of these viruses that can recombine, that has great, huge pandemic potential, that can go into other, animals like chickens and pigs and many other animals. So whenever you see, just a quick shorthand here and a take home is when you see H3N2, H1N1, H5N1, generally we're talking about influenza A. And it's a specific type of influenza A. And you can see there's a lot of other pieces there around geographic origin, strain number, year of isolation. But most folks, shorthand will just be that virus subtype at the end, referring to some of the proteins on the outside of the virus, the hemagglutinin and neuraminidase, that are actually used to bind to our cells, right? So that I mentioned earlier. Compare influenza A, what I just talked about, these zoonotic viruses that can lead to huge pandemics that we see every year, causing the vast majority of influenza infections, and influenza B. And what's different is influenza B typically only transmits in humans. Now, there are more than A and B influenza viruses, but the ones that really cause problems for us are A and B. And what's interesting is that because influenza B only transmits in humans, we don't see this recombination events happening like we see in the ones that recombine in animals. And if you can hear banging behind me, there's nothing I can do about it. There's construction going on. It's very loud. I'll try to do my best to keep rolling here, but let me know if it's...
I don't think we're picking it up at all, but I
Okay.
know that feeling. It's always a little distracting.
It sounds like horses beating their hooves in the walls right now, but I'm going to keep going. So influenza B is very different. So we typically see a big influenza A surge in the winter, and then often, not always, then we see sort of an uptick in influenza B as the end of that season. So a classic influenza season is a big A season, typically, most recently H3N2 or H1N1, and then it drops down. Influenza B picks up or sort of takes that tail in later in the season, the one that extends the season going further into the late winter. So really interesting. One little other quick tidbit here is that typically, if you go back before the COVID-19 pandemic, our influenza vaccines contained 4 antigens, 2 A's, the best predicted ones we can cover. Most recently, a type of H3N2 and a type of H1N1. And then there's actually 2 flu B strains, the Victoria and Yamagata strains. But what's really wild is that because of the things we did during the pandemic around distancing, mask wearing, staying home or sick, and testing, those were wildly effective against influenza in general. And we actually extinguished one of the influenza Bs. So we don't actually have a quadrivalent vaccine anymore that we used to require. Now we have a trivalent vaccine because we don't see one of those influenza Bs anymore. It's completely gone from the planet because it only circulated in humans. We don't have to worry about it reemerging from animals. Really interesting outcome of the pandemic that we completely did not expect. So where are we? These are data from Washington State Department of Health. I'm not going to go through every bit of this. This is just data from I pulled up last week when I was putting these slides together. But what you can see here is just basically the number of laboratory tested influenza tests they've had at the Department of Health that have been reported. So this is not every test in the state, just is the ones that get to their lab. You can see that as of this year, our influenza activity is pretty low. We have actually already had a lab confirmed death in Washington State during this season. And the most common type of influenza circulating is A. What I really want to talk about really briefly is in that purple box in the bottom left. It gives you a sense of what we're seeing out there, right? So you can see that the strains that we're seeing are mostly influenza A's. So at 2009 H1N1, that's a kind of a flavor of the one we saw back in 2009 with the big pandemic at that time. And then we see some H3N2s also occurring. Again, small numbers, but gives you a sense. And then farther to the right, you see Bs. So we are seeing some influenza Bs at this time of year. And what I'll tell you just as a take home here is that I've been doing this work for 15 years. I think this is my 16th influenza season that I've been very deeply involved in and paying attention to, is that I cannot tell you what each season is going to look like. And each season has been unique. We've had seasons where we've been mostly B. We've had seasons where we see all, 3 different or 4 different influenzas circulating. We've seen seasons where it's all one big A. Some that happen early, some that happen late, some that are short, and some that are long. And so it's very, very hard to predict what influenza season is going to look like. So even seeing this many Bs at this time of year, it's a little unusual for us when you think about the typical or stereotypical patterns of influenza transmission. We should also just pay attention, I think it was last year, some of the times these things run together, avian influenza, these H5N1 strains that we started seeing circulating in the United States. Historically, we'd seen H5N1 outbreaks mostly in, fowl wild birds, which are the main movers, right? So another zoonotic type of influenza, like type of influenza A. And it would move through flocks. These would lead to massive culling interventions. And we'd occasionally see people test positive for H5N1 who often were interacting with those birds. And the real challenge here is when this H5N1 binds to a specific receptor that's deep down in our respiratory tract. So that blue sort of cauliflower thing, those are our tiny little alveoli where gas transfer, oxygen, carbon dioxide moves between our circulation and our respiratory tract, right? And this particular virus binds to a receptor way deep down there called sialic alpha 2,3 galactose. And because it binds just those receptors down there, when it does bind, it causes very, very serious disease in general. And it's also a little bit harder to transmit. At least that was our thinking until this last year when we started seeing all these cases happening in North America and often in people who weren't very sick at all. And what we looked at in retrospect probably is that, yes, some people get very, very sick and end up in the hospital. We had a child who's otherwise healthy in British Columbia who ended up in the ICU because of this infection due to this. But we've seen a lot of people with very mild infections or something as simple as sort of red eyes, right? And what we probably have seen is that a bias towards testing sicker people, right? When people are very, very sick in the hospital, you can't figure out what's going on. You end up doing a lot more tests on them. And so we end up finding people who are with H5N1 who are very, 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 very sick. But we weren't really doing tests on people who weren't sick or not sick at all, but may have had exposures. So there's some bias in how we understand H5N1 and its pathogenesis, how it makes us sick. But definitely more to learn. It's been a very unexpected experience in this last year, but it is still out there and it's something we pay very close attention to. In the UW medicine system, we've been typing all of our influenza A's for not only the sort of the H1N1 and H3N2 that I just showed you, but also for H5N1 to keep an eye on whether this could potentially be emerging in our community. Fingers crossed we won't see it again. RSV, in terms of its burden in the community, I showed you some data on the impact of influenza. RSV, as I mentioned, we used to think about this as a sort of a neonatal disease caused a disease called bronchiolitis obliterans. Children were very, very difficult to breathe. But what we know now is it causes a lot of disease in a lot of folks. And you can see in this chart from the CDC that if you look at preliminary data from 24 to 25 in the United States, there's somewhere between 3.5 and 6.5 million outpatient visits due to RSV in the United States alone. 190,000, 350,000 hospitalizations due to RSV, and between 10,000 and 23,000 RSV deaths. So this is a huge deal for people here in the United States, and really importantly in other parts of the world. This is going to be a little hard to see for everyone. I don't know, Anna, whether we share these slides. I'm happy to share them with folks, but I think it'll also be up on YouTube. But this is from a recent series of papers looking at respiratory syncytial virus. And this paper was called RSV Infection and Novel Interventions. And I'd say sort of the take homes here is that if we look at sort of children, that's the left-sided, so children under 5 years of age on the left side iceberg, and then folks who are greater than 65 years of age and older on the right side, right? It gives you a breakdown across the world. If we look at the global burden of RSV, you can see 33 million RSV lower respiratory tract infections, with greater than 95% of those in low and middle income countries. Greater than 100,000 RSV deaths, the vast majority again happening in low and middle income countries. 3.6 million RSV hospital admissions, high mortality rates, but also below that, are the stuff we test for is, clear increases in asthma, other respiratory tract infections in children, respiratory tract outcomes in children, and the economic burden of all of these infections. Similarly, on the right, for older adults, millions of infections, millions of medically attended, office visits and hospitalizations, but also big impacts on things like long-term frailty. So how people are able to recover from a serious respiratory tract infection like RSV, especially if they're hospitalized or end up in the ICU. The impact on economic burden of these, and the community burden, particularly in low and middle income countries that we have in the same outbreak or epidemic. You're seeing impact on babies, children, and older adults all at once, and even in the same household. This is looking at, again, these are CDC data, looking at hospitalization rates per 100,000 population. You can see we saw a big steep peak back in late 2024. And you can see about 1.2 per 100,000 infections as of right now, but it's going down. And then you can see the percent of, this is COVID-19. So we see those two peaks. So we saw the big peak in the winter of hospitalizations due to the winter of 2024-25. Then we saw that summer peak in July to September of this year, but again, dropping quite quickly. And then you look at the bottom graph, again, from the CDC, it's just looking at the percent of all deaths in the United States. And again, we saw sort of this biphasic pattern where we saw a peak up in the winter of last year, and then it went up during the late summer. These data, the reason you don't see it going down is because death data are typically delayed in terms of reporting. But the take home here is if you just look at the death data over the last year, there have been points literally in the last 12 months where 2% of all deaths in the United States were directly attributable to COVID-19. So as much as we want to put this virus behind us, and I sincerely hope we someday will be able to, it is still a very important part of our lives. And it really causes a lot of morbidity and unfortunately mortality. I mean, that just blows my mind. Between 1% and 2% of all deaths in the United States at given periods of time are due to COVID-19 still. Where are we right now? Where we are. So this is Public Health King County data looking at COVID-19, influenza, and RSV emergency department discharges. So if you go to the emergency room and you get diagnosed with COVID-19, influenza, RSV, right, that goes into a system that Public Health King County is able to share with us. And you can see that in the top is COVID-19. So we did have a summer surge where we got to, just under 2% of all emergency department discharges were diagnosed with COVID-19. Influenza, you can see our last phase was back in the winter of 24-25. And then January, you can see RSV was even earlier than that. I would say that peak of sort of January for us of this year for RSV is pretty late. Typically happens in the earlier part of the fall, but again, very unpredictable. But fortunately, right now, this is the end of October. We're now a week out from that. You can see very low rates of influenza and RSV in our communities, which is a great time to be doing things like vaccination as a way to mediate the impacts of these viruses. Okay, so how not to catch a virus, right? So that's the sort of the crux of all of this. Sorry, I'm just again trying to mediate these banging behind me, the horses here in my walls. So one of the key take homes here that people may not always focus on when they think about preventing respiratory viruses is ventilation. So ventilation beats vibes. Fresh air dilutes germs. I would say here at Harborview, where I work and where I was part of the COVID-19 response, one of the most important groups and the folks that I high five to this day is our facility and engineering teams, because they were the ones who kept our ventilation system working. We have essentially 100% fresh air that comes into this hospital. We don't need to recirculate, so the issues around filtering aren't as big of a deal. And I think that kept us extremely safe. And so wherever you are during the respiratory virus season, the fresher air you can be around, the better off you're going to be. And to be clear, the houses we live in, the apartments we live in aren't built to ventilate, right? I live in a house here in Seattle. Ventilation is opening windows or closing windows, opening doors, right? Heating systems have filters in them, but they're not necessarily diluting air in the way we think of in, for instance, a hospital or necessarily a commercial building. So this is part of the reason why being outside is safer than being inside, right? Or being away from someone who has an infection, or keeping yourself home when you have an infection. Because if you are expelling those viruses into the aerosols, into the air around you, that's where we see transmission occur. We can do things when we can't be in perfectly fresh air, and one of those things are masks. Masks protect the person wearing the mask, and they also protect those around us. And the more of us who wear masks when these viruses are circulating, the more powerful that intervention is. And of course, like I mentioned, if we're able to stay home when we're sick, that is critical, right? As soon as we start feeling ill, we got to stay home. And this is a huge equity issue because a lot of people, there's downsides to staying home. And so we need to support policies that allow people to stay home and not necessarily lose their income, right? So they can make the right, best decision, both for themselves, but also their coworkers and other people they interact with. And then obviously wash your hands all the time is always a good idea. As an infectious disease doctor, I'm a big fan. But it's also important to recognize that when we think about, masks, eye protection, some of these other interventions, that's when we can't do all the other things. And this is sort of this is called the hierarchy of controls. It's published by the CDC's National Institute for Occupational Safety and Health. And this is, I'm not going to go to every bit of it, but it occurred to me when I was putting this talk together, this would be a sort of a useful framework for folks to at least sort of have in their head, or at least think about. And it's how do we reduce hazard, particularly in the workplace, right? So as a medical director for employee health, what interventions can our team on the employee health side do, or the hospital do, to reduce hazard, reduce risk from all comers in the workplace setting? But if we think about viruses, right, we can put this into prevention of workplace transmission. We can put that same framework to play here, right? So the hazard in this case is a respiratory tract virus, an infection. And what people often think is, I'll wear a mask or something similar. And it's important to recognize that that's the lowest and least effective tool we have, right? So if you wear a mask, that means you are probably going to be exposed, right? If everyone's wearing a mask, the idea is we are circulating at such a high level that we need to do something, because I'm going to interact with that as a patient, as a member of the community, as a worker, right? And so I'm going to wear a mask. That means I'm going to see this hazard. And that's not the goal, right? We don't want people, as to give sort of a similar situation. The perfect situation is no facilities engineer ever cuts into something with asbestos, right? If they have to wear like a PPE to reduce the risk of sucking in asbestos, that means we have no choice. The better situation is to be at the very top here, physically remove the hazard. If we have no asbestos in our buildings, then our facilities colleagues never have to cut into something with asbestos, right? That is infinitely better than having to wear PPE. And the same thing occurs when we're sick, right? If we're sick, right, staying home is going to be way better than coming to work with a mask on. Similarly, if we are vaccinated and we don't get infected, we're eliminating that virus from ourselves. And the more of us that get vaccinated, we can actually eliminate virus circulation in our community, thereby eliminating it, right? So if those emergency room discharges here at Harborview and UW Medicine, we require all healthcare workers to wear a mask when they're in patient care spaces. When that discharge, those ED discharges get to a certain level. If they never get to that level, we don't have to wear a mask because the rate is low, right? We've eliminated the risk rather than having to protect ourselves through PPE. And I think this works out in our everyday lives as well, right? What are the steps we can take so we never have to wear masks in our community and knowing we're going to have to interact with these viruses? Okay, everyday armor for respiratory tract infection prevention. Fresh air I mentioned, clean hands, up-to-date vaccines, which I'm going to talk about, staying home when we're ill, supporting policies that allow people to stay home when they're ill, respecting space, right? Giving people space when these things are happening. These all feel incredibly boring, but it's these boring things that save lives, right? I've learned over time how powerful a policy can be. No one's a huge fan of writing policies, implementing policies, but they have huge potential to keep all of us safe in our workplaces, in our lives. Okay, let's jump into vaccines. So vaccines are all about training our immune response. As I mentioned, that adaptive immune response. When we see a virus, we get an infection, our bodies then develop an adaptive immune response where our B cells and T cells and other parts of our immune response start targeting pieces of the virus, what are called antigens. And what a vaccine basically does is it delivers just the antigen to us so that our immune response can adapt, right? Build a specific immune response to that specific antigen that's part of that specific virus. And what's cool is that once it builds it up, it kind of builds up, it kind of calms down, but now we have a library that's ready to roll, kind of like an army in waiting that's sort of ramped up, it's targeted towards that specific virus. And what's cool with a vaccine is that we can generate that army in waiting without ever actually getting sick, right? The same process generally works with infection, but we have the downsides of getting infected, potentially giving to other people, maybe end up in the hospital, the emergency room, or even dying. And vaccines can prevent all of those steps and allow us to have the upsides of having a targeted immune response that can go after that infection. And we use these vaccines. So flu, we get these yearly updates. I just got my flu shot yesterday in our employee health clinic. RSV, some new shots. I'm not eligible for that shot just yet, but if I was, I would get it. And then COVID updated boosters, which is on my to-do list for the next week or two in my community pharmacy. Or thanks to Anna through Seattle Visiting Nurse Association, the whole U. So it's important to recognize that vaccines not only protect the person who gets vaccinated, but the more of us who get vaccinated, just like the more of us who wear masks, we protect more people in our community, right? The more vaccinated people there are in a community, the lower the risk is for transmission, right? And increase potential for eliminating transmission in that community. It's also really important to recognize there are people in our community who can get vaccinated 10 times. It's not going to work, right? They may not be age eligible. You're under 6 months of age. You may be getting a solid organ transplant. You may be getting cancer chemotherapy. You may be getting an immunosuppressive for a terrible immunological disorder, right? That can be effectively treated with a biologic. And again, I can vaccinate all those people who desperately want to get vaccinated and desperately don't want to get sick to COVID, from COVID, RSV, or influenza, but it doesn't work. And they're counting on us, right? Those babies, those older adults, those folks whose immune responses won't respond to vaccines. And so the more of us get vaccinated, the more we protect ourselves, our families, our loved ones, our communities, our friends, but also folks who vaccination isn't an option. And that leads us to this idea of herd immunity, because not everyone can be a lone immune wolf, right? It's not about just ourselves. It's about protecting ourselves and everyone on the long list of people I just mentioned. Okay, so what is our flu vaccine composition for this year? Again, I won't go into all the crazy details of this right now, but it's kind of cool to know. So as I said, every year we look at what's circulating in the Southern Hemisphere, and a group of experts from around the world come together and say, this is the most likely influenza viruses that will be circulating in North America, and South America does the same thing for their vaccines. And so what the recommendations for this year's vaccine right now, as I mentioned, trivalent, 1B and 2As. So it's either the Victoria, Wisconsin H1N1, so that's the blue at the top. Croatia or DC one, those are both H3N2. So the two most common influenza A circulating right now are a type of H1N1 that are derived from that 2009 outbreak. That's why it's called PDM09, and H3N2. And we've seen this for the last, I guess, actually last 10 years, some variant of these two viruses. And at the bottom, you see it's the Victoria lineage. That Yamagata strain that I mentioned, that influenza B, is gone. We don't see it at all. So we don't have to worry about it. And so just this Victoria lineage from 2021 that is in the vaccine. So the recommendations were to contain these three antigens. So one of the top two, one of the middle two, and then the last one at the bottom. There's lots of vaccines out there. Again, I'm not going through all these details. You're happy to have these slides, but we have a lot of options out there. We have the trivalent IM vaccines, the intramuscular vaccines. We have the return of FluMist this year, which is an intranasal vaccine that I believe you can take at home. Now, you can get it done at home. You can self-administer it, which is pretty cool. There are some limitations. You can see the age group there is 2 through 49, and I believe not for anyone who's immunocompromised. But for healthy people between 2 and 49 years of age, you can do your own vaccine at home via intranasal route, which is pretty cool. For RSV vaccines, finally, as I mentioned, this is a huge disease, and now we have some vaccines out there. As I mentioned, I'm not quite in the age category yet, but some folks on this call may be. We have 2 different vaccines for adults 60 years of age and older, and one of those vaccines can be given to pregnant people, which is super cool because of the impact on neonates and very young babies. So this is fantastic news, and has already proven to have a huge impact on neonatal RSV acquisition and RSV in older adults. So really, really cool stuff. I will also point out for babies who are born to a pregnant person who did not get the vaccine, there's also monoclonal antibody. So this is an antibody like the antibodies we make in our own bodies, but it's targeted just to RSV. That's one of the antigens there. And this can be given to for infants. And it once per season, ideally before fall, winter. So really cool by giving. So now we have vaccines and we have monoclonals for neonates who or babies whose parent wasn't vaccinated and can protect them. And this again can have massive impacts on RSV acquisition in our community. And this one, the target here is the fusion protein. So that's the antigen for this monoclonal. COVID-19 vaccines. So these are being updated quite regularly. As you've probably seen a lot of the conversations going on, there was initially a lot of confusion over the spring and winter. We have some clarity here in Washington State, especially as part of the Western State Health Alliance, with Washington, California, Oregon, Hawaii, all aligning around the data and science that's out there. So basically, COVID-19 vaccines are recommended for everyone 6 months and older. There are boosters available for those who are 65 and older, immunocompromised individuals, and for healthcare workers. This is right now an annual update, a lot like flu shots that tracks current variants. Right now, mostly the KP2 lineage. I did say there are summer bumps and there are winter bumps, and for reasons that are kind of complicated, we're still like updating typically in the fall, preventing that winter bump. And that's why we aren't doing it, twice a year right now. Hopefully that protection can carry over to subsequent years. And the data is still very strong, showing that this does have a measurable reduction in infection, but the big impact is on ending up in the hospital, emergency room, the ICU, or dying from COVID-19. And these are 2 different flavors of vaccines, either an mRNA vaccine or protein-based vaccine. That's the Novavax vaccine. And again, trains immunity against the most recent COVID-19 variants that we're seeing out there. So still a great recommendation for pretty much all adults. Quick myth busting, because I do continue to hear these. Some people say, flu shot can give you the flu. That is not possible because the flu shots don't contain the entire virus. So you can't get the flu if you don't have the entire virus. Just not true. You may have a sore arm. You may feel kind of tired. You may even have a low-grade temperature. But none of those things are the flu. And it's important to recognize that that adaptive immune response that the vaccines give us takes a couple of weeks to kick in. So it is possible you get the flu shot, and if you did it, when flu circulated, you get the flu still within that first week or two. It doesn't mean the flu vaccine didn't work. It just means it didn't have enough time to give you that adaptive immunity. Another myth busting thing here is RSV isn't serious in adults. It absolutely puts people in the hospital. It absolutely puts people in the ICU, and it definitely kills people. We used to think this was a baby disease. It is definitely not. It impacts our entire community. Next one, COVID's over. It's not. I showed you the data around the deaths associated with COVID-19 infection. At certain points in the last year, between 1.5% and 2% of all deaths in the United States in some months were due to COVID-19. And so when you hear these things out there, or you yourself think about them, double check your sources if you hear these types of messages coming out there. What do you do if you're sick? I'm a big fan of rest fluids and fever reducers, things like acetaminophen are the biggest one. If you can't eat and drink and get yourself to the bathroom, that's when you probably need help, right? If you have any trouble breathing or similar, please seek help. Use antivirals early if prescribed. This is for influenza or COVID-19. We don't have a good antiviral therapy for RSV unless you're in the hospital and quite ill. Viruses don't respond to antibiotics. So things like azithromycin, right, a Z-Pak, have no impact on these viral infections. And again, as I mentioned, if you can't eat, drink, make it to the bathroom, if you're having trouble breathing, you have chest pain, confusion, or someone you know or love is exhibiting these symptoms, please get them to emergency room so they can be taken care of and supported. With early intervention, we can make a huge difference in people's outcomes should they get sick. Flu and COVID testing and treatment, right? So there's a lot of flu tests out there. There's a lot of COVID tests out there. They're typically the ones we do at home are what are called antigen-based tests. And they're okay. When they're positive and you have symptoms, they're great. When they're negative and you have symptoms, you may need to test again. And so they can be a little tricky. They're not always the best tests, but they're what's available out in the community. If you end up in an emergency department, they're probably going to use a different type of test, most typically a PCR test, which are very sensitive. And so if there's symptoms and they're positive, they're very good. If there's symptoms that are negative, it's probably due to a different respiratory tract pathogen. Treatment for these, I'm not going to go all the specifics, but if you come into the hospital with something like COVID-19 or influenza, definitely need to be treated. Anyone with severe, complicated, or progressive illness, people at high risk for complications from COVID-19 or influenza. So people with any organ involved, basically, you can see in that list. People who are immunocompromised, people with disabilities, pregnant people are at much higher risk for disease progression. And really importantly, there are people from communities in Seattle, right, in King County, in Washington State, who are high risk for hospitalization. People coming from Native American communities, people coming from Hispanic communities, non-Hispanic Black communities, right? So there are definitely people with higher barriers to care through structural issues like racism that definitely impact their outcomes. And so making sure that individuals in those communities have access to care is really key. And then for the one other group here is non-high-risk people in the outpatient setting within 48 hours of illness onset are also candidates for treatment for flu and COVID-19. But it has to be pretty early. After like 2 days, those drugs, oseltamivir, and don't really have much of an impact. So beyond that, if you're doing okay and at home eating and drinking and things like that, it's been a couple of days, probably treatment at that point is not going to make a big deal. Okay, lessons from the pandemic that apply to what we're talking about. And I kind of touched on this, around vaccination, around masking, around staying home when we're ill. We are all connected in this. These infectious diseases impact all of us. None of us made it through the pandemic without some sort of impact on us. And that's true for many, many people with RSV, with influenza and similar. These public health interventions work. Masking works. Staying home when you're sick works. Getting tested works. Getting treated works, right? But we have to use them. When we come into work sick, or we have an environment where our workplace doesn't support us when we're sick, right? Then those interventions aren't going to have an impact. It's also important to recognize that science evolves, right? That's a feature, not a flaw. Things change. And so it's what's right one day may be different a year later, or even a month later. And so we need to be able to listen and be able to adapt to those different changes. The future is pretty exciting around this. There's a lot of cool vaccines coming out in the future. So new mRNA vaccines. There's even a updated one of the mRNA vaccines for this year is a little more focused, which is pretty neat. There's a lot of data coming around universal flu shots. So you don't have to think about which A's and which B's. You just get one flu shot that targets all of them. We're hopefully better antivirals and better systems that allow people to get treated. Like that flu mist that you can administer at home. I think that's great for a lot of people, right? You can go to the store, you can buy it, you bring it home, you do it. People who have a lot of fear around needles and similar, right? Access to interventions is great. And maybe even better nasal vaccines. Although the flu mist vaccine, hasn't hit it out of the park any more than the IM vaccines, intramuscular ones. That's where the virus is attached. So we can build better immune responses in our nasal passages through mucosal vaccines. That will be very, very cool. I will say this issue around vaccine hesitancy in the last couple of minutes here is a big deal. I just want to acknowledge that. There's a lot of misinformation around vaccine hesitancy, and this is a World Health Organization top threats to global health. It was published in 2019. You can see some of the things you'd expect on here, like, Ebola, antibiotic resistance. But you can see number 8 is vaccine hesitancy across the spectrum of vaccine preventable illnesses like RSV, influenza, and COVID-19. And I just want to highlight, when we hear things like this, when we hear the vaccine causes flu, right? Or we hear that COVID-19 doesn't cause a problem, I would say that is some sort of contested information, misinformation, disinformation, malinformation. And we all have to stop, think about the sources where those are coming from, ensure we're looking, maybe not better coverage is the wrong way, maybe more diverse coverage, and make sure we're tracing claims back to the source so that what we're understanding and what we're then propagating is based on the best science that's available. So the bottom line, these viruses evolve. When I started my work in infectious disease in 2000, well, actually way before that, 2002 as an infectious disease doctor, I never thought I'd be where we are right now, but we are. And so we have to be able to respond to that evolution. Vaccines, fresh air, and kindness go a long way, right? Because that's ultimately what it's all about. Healthy lungs, happy life, and fewer sick days for all of us is the outcome that I wish for going forward. Oops. So yeah, ask me anything except to predict the next variant.
Awesome. Well, thanks so much, John. Such good content. I'm just going to go ahead and start off with the first round of questions we got, and we'll just keep moving through. If folks want to raise your hand, you're welcome to do that too. The first one we got is, can you just expand a little bit on what you mean by antivirals? Like if you're prescribed those, what are they? And
yeah, so antivirals are drugs that we use to target viruses. So we're not nearly as good about viruses and viral infections in terms of drug treatments as we are for a lot of bacteria. Lots of antibiotics, very few antivirals. And the antivirals we have often aren't awesome. So the ones we think about influenza is oseltamivir. That's called, commercially it's called Tamiflu, is probably the most common one.
all right. Another question we got is, how long does the RSV vaccine last?
That's a great question, Gretchen. And off the top of my head, I don't remember. I can try to find the answer, or maybe someone else can take a quick look. I don't believe it. I'm trying to remember whether it's an annual vaccine for folks who are older or not. For pregnant people, it's every pregnancy. I know that. And for adults, older adults, I don't remember how long it lasts for, whether it's an annual vaccine.
My quick search said varies based on age. So
yeah, so that's why maybe.
yeah, thank you. And it looks like you can see these. You can see Heidi asked.
I can just read them if you want.
Yeah,
So
sounds great.
do fevers actually do anything beneficial in fighting illness? It's controversial, Eric. There are some data supporting people with higher fevers having better outcomes. But it's tricky because it depends upon which infection you have. So I would say for the vast majority of the time, unless you're like critically ill, you're in the hospital where, those studies have sort of looked at outcomes. If you're at home and you have a fever, you don't feel good, taking acetaminophen and bringing that fever down isn't a bad thing, right? It's not going to be the thing that drives you to, ended up in the emergency room or something similar. So I like acetaminophen. I don't give it to people just for a fever. I give it to people because they feel badly when they have a fever, right? Muscle ache, soreness, headache, things like that. Anna put in some more vaccine clinics, so please get out there and do them. From what I told my colleagues here at Harborview, they've been super good, super easy, very professional. Heidi, RE, the everyday armor. I know you said the goal is not to have everyone to wear PPE, and like you, I'd love to eliminate those hazards posed by viruses. But since we're not there yet, and given the current risks and long-term effects of repeated COVID-19, should high-quality masks like N95s and K95s be part of our everyday armor? So, Heidi, you're absolutely right. So first, N95s and K95s are a type of respirator, and respirators are absolutely better than surgical masks. So I think that when these viruses are circulating, or if you're at risk, or you simply choose to step up and do it, wearing the highest quality respiratory protection makes sense. So if you're good with N95s or K95s, 100%, those are going to be safer in terms of transmission risk and acquisition risk. And we can see how these things work, right? This is what we use with respiratory tract infections for healthcare workers. When someone's taking care of someone with COVID-19, they have to wear a respirator, no ifs, ands, or buts. So they absolutely work better than something like a surgical mask. So yeah, we're not there yet. And wearing masks in especially crowded indoor places makes a great deal of sense. Okay, Heidi also asked, what do you think about portable HEPA filters and Corsi Rosenthal boxes for ventilation, places like homes or offices that don't have great ventilation built in? I think they're great tools. We have not paid as much attention as we should have in how we handle air in indoor settings at work or in other spaces. This office I'm in was built in 1930. It's like 150 degrees here during the summer. I have a radiator over there that I never turn on, and that's my ventilation, that window, which is open pretty much year round because there's nothing else. There's no air input, there's no air exit. And so I depend upon that. And that's okay until it gets really, really cold. And so we do need to be putting things like HEPA filters and, Corsi Rosenthal boxes, are inexpensive ways to use box fans like in a cube in your home they're really nice. You can find that if people are interested in doing it, you just use furnace, I think, filters or HEPA filters, box fans that you buy at home, and there's plans online how to do it. So I think we should be seeing way more HEPA filters in all spaces, particularly during the respiratory virus season, because we're not built for it. And Bryce gives it a +1. I give it a +1 as well. Shanae, I hope I'm pronouncing that correctly. Please correct me if I'm wrong. Growing up, it seemed like green, yellow mucus was the telltale sign of an infection versus a virus, and it meant we needed an antibiotic. What are your thoughts on that? So we actually do have data on that. So the color of your sputum or mucus has no relationship with whether it's a viral infection or a bacterial infection. You can get either or in either type of infection. So just because you have yellow green mucus does not mean you need an antibiotic. Most infectious, respiratory tract infections during the fall and winter, when COVID is circulating in the summer, are due to viral infections, vast majority of the time, and they can make nasty looking sputum. Do you have any advice on what to say to those who are vaccine hesitant? I know at 1 o'clock, Anna, so you might have to shut me off here, but I think this is a good final one. My advice is be humble and listen. And, I like this idea of sort of advocacy inquiry, where my ask is, tell me more. Tell me more about your position so that I can understand and hear what you have to say. And then I think it's going to take repeated conversations where it's the same humble approach of listening and trying to understand where they're getting their information from. What are they worried about? What are they scared about? It could be a parent who just sees putting, vaccines into their child, and their job is to protect their child, right? And so how do we address that, hear that fear, right? Sometimes concern or other things, and provide information as they're ready to hear it. So humility, advocacy inquiry, tell me more is my MO there. Where there's gross disinformation, fighting against disinformation, because there's disinformation actors. That's where someone's deliberately sending the wrong information for another reason. It's also called malinformation. We got to work there. I think, Anna, I don't want to go over
Yeah.
time for everyone.
We
I know
did,
one.
yeah, we did get one more question that I think it was a direct message to me that I think is a good one to close us off with, if you have a moment. Is
Absolutely, I
one
do.
person asked, is it okay to have all three vaccines at once? I know that's a hesitancy sometimes folks have, like
Yeah.
maybe they end up just getting one because of concern or.
Yep. Yes, you can get all those vaccines. There's really good data on flu and COVID, which is the vast majority of folks. No problem at all. And what I always say is whatever's convenient. You know, people talk about timing, and there's a lot of papers and data out there about optimal timing. It's tricky because you actually don't know when these viruses are going to pop up. You know, you don't always have a 2-week lead time. And so what I try to tell people is, if you're in your primary care doctor's office in September, get it done, right? Just make it whatever's convenient, because we know if you don't do it, it tends not to happen later in the season.
Yeah. Well, thanks so much, John, and everyone who stuck around. We really appreciate all this information. It's just such a good reminder that there's so much we can do ourselves.